Good morning, everyone. I am Dr. Nat Kittipongphat from Faculty of Medicine, Siriraj Hospital. Today, I would like to present the topic Revision ACL Reconstruction, How to Avoid the Failure. Thank you, my advisor, Dr. Pop Ganokrath, for good supporting. One of the most concerning outcomes after ACL reconstruction, or I will call ACLR, is graft rupture. While the native ACL can fail, reconstruction ACL are also susceptible to failure. In that case, revision surgery becomes necessary to restore knee function. So today I would like to talk about 5 pillars we have to know before revision ACL reconstruction. First, the primary ACL reconstruction failure. The patient dissatisfaction after primary ACL reconstruction is divided into 3 main categories. It's a recurrent instability or graft failure that can be divided to early phase and late phase. The next is a post-operative complication such as infection, loss of motion, or development of arthritis. And the last is pre-existing or comorbidity such as extremity alignment and meniscus tear. In the recurrent instability or graft failure, we can divide it to early phase that is composed of technical error, unrecognized associated injury that can cause the secondary resistance failure, the malalignment of lower extremity, premature return to sport, and biologic failure. While the late failure often occurs with non-contact trauma, which is the most common cause of the re-rupture. After identifying the cause of failure, preoperative evaluation and planning should be performed in all patients. In addition to the fundamental data like symptom and patient activity level, previous surgical history is critical to determine the cause of injury. Other associated injuries such as ligamental and meniscus injury, and also the type of graft fixation should be evaluated. To assess the post-operative cost from primary surgery, rehabilitation and return to competitive play also need the data. A full examination of the knee should also be performed. The malalignment, especially varus deformity, can increase the strain to the graft and be the cause of the failure. Flexion and extension deficits may be required concomitant surgical procedure. The AAP and rotational stability examination and also varus and valgus test should be performed to evaluate the ligament in the knee. For the imaging, radiograph evaluation still be the first line test of the evaluate some fundamental parameter. The standard AP and lateral always should be performed first. The merchant view can evaluate the patellofemoral chain degenerative. Long leg weight-bearing radiograph can show malalignment of the lower extremity. Secondary radiograph, including varus and valgus tests, may be requested in the suspicion of multi-ligament knee injury. The CT scans are more reliable to evaluate bone tunnel, including tunnel position, expansion, and integrity of the bone stock. They provide fundamental information when choosing a one-step or two-step surgical approach. The MRI is mandatory to evaluate the integrity of the knee ligament and status of the articular cartilage and meniscus. Next is a surgical step and consideration. The first step is diagnostic arthroscopy that we have to always perform in every case. The general principle of the ACLR can apply to the revision surgery, but the debridement must have to adequate to visualization and also see the fixation point on the both bone to see the previous graft, also cyclop lesion and the left instrument. Next is about the hardware removal. The interesting question about the hardware is we will remove it or not. So the answer has just two, is remove and leave it. So if that hardware is loose, we should be removed regardless its positioning. But if the hardware is secure, We have to evaluate the position of the tunnel relative to the hardware. If the tunnel is from the previous surgery, a significant malposition and completely new tunnel can be overdrilled, we can prefer to leave the previous hardware in place. But if the tunnel are only partial malposition or in the correct position, the fixation device may be need to remove. Often bioabsorbable screw can be overdrilled, but non-bioabsorbable screw often must be removed. And other fixations such as suspensory fixation and the screw and the probe can be left in the place. Next is a tunnel preparation. This step is one of the key man of the revision. So the decision is provide at 1 or 2 stage revision depending on multiple factors that must be considered. So even though it is not frequent, a 2-stage revision is mandatory if an infection is suspect. And planning a 1-stage ACL revision in the case of significant range of motion deficit required to analyze the cause. So if it is not detectable or is due to severe arthrofibrosis, a 2-stage surgery is recommended. The most important factor to consider for the proper decision of the 1 or 2-stage surgery is the location, dimension, and morphology of the previous bone tunnel. The problem of the previous bone tunnel is the widening, which this can happen from either fixation, the bungee cord effect from the suspensory fixation, and also the windshield wiper effect from the interference screw. This can make graft tunnel abrasion, which can cause the osteolysis. For a 2-stage procedure, using bone impaction grafting to support the new bone tunnel is the step of this method. Most reference consider that diameter more than 12 millimeter is a cutoff of the considered revision in 2 stages. Anyway, no absolute threshold existing for the critical tunnel diameter. And some reference suggest that a 15 millimeter or even more, 100% of the previous tunnel can be the limit of the 1-stage revision. The bone plug should be 1 millimeter more than the tunnel diameter to make it a press fit. And autograft and allograft can also be used as a bone grafting in this method. And after bone grafting, CT scan should be confirmed at 3 to 6 months. For the tunnel widening, even in case of diameter larger than 50 millimeter, some techniques have been described to bypass the problem of the new gap in the former tunnel widening if a 1-stage revision is required. In case of good bone quality and anatomic tunnel, divergent technique at the old footprint is available. But if the bone quality, stacking screw and mastic technique is an option to do it. Moreover, we also can use the over-the-top technique and outside-in technique to bypass the tunnel widening in a 1 stage. For the tunnel creation, there are 3 types of former tunnel that we must analyze. The misposition of the tunnel is anatomic, non-anatomic, and semi-anatomic. When the position of the previous tunnel is correct or the anatomic position, only the diameter should be considered. If no enlargement of the tunnel, reuse tunnel by merging with the previous one can be done with any graft choice. If present of the severe osteolysis, a 2-stage procedure is a more recommendable way to do it. However, 1-stage procedure, as described before, can be available option for this problem. If the previous tunnel are completely out of the way or completely incorrect position, to create the new one in the one state is an available option. However, if an old tunnel is significantly enlarged to less gap than 2 mm from the new tunnel, there is a risk of tunnel collapse between the old and the new one. Filling the old tunnel with the interference screw or bone graft is useful to avoid the collapsing. In the case that we use BPTB graft, rectangular tunnel creation has an advantage to avoid the tunnel collapsing. For partially anatomy or overlapping tunnel interference is expected. The stability and the integrity of the new graft may be compromised if the tunnel communication. For this case, a two-stage procedure is more recommendable, even though some rescue procedure that allow for a one-stage revision has been described before can also be used. This is the concise diagram flowchart for the tunnel preparation. Next is a graft selection and fixation. The choice of graft fixation, also the autograft and allograft. There is no standard graft in ACL revision. However, allograft have a higher rate of failure in young athletes and a slower incorporation. So the graft used in primary ACL reconstruction and the presence of the severe tunnel bone widening and the concomitant injury deficits of ligament are the three fundamentals that have to determine for choosing the new graft. BPTB, hamstring, and quadricep can also be used as a donor graft without significant difference of the clinical outcome in terms of knee stability and failure rates, both ipsilateral and contralateral side. However, ipsilateral BPTB reharvest has been proposed in some journal, but is not recommended due to the higher rates of complication and poorer functional score. The one disadvantage of the hamstring is related to the graft site, which may be the limitation in the severe tunnel enlargement. The fixation site is the weakest component of the revision ACLR and being cause of the early biomechanic failure. So the graft fixation site should be assessed for the quality of the bone and the relative size of the tunnel and graft to achieve adequate fixation. Without tunnel expansion, interference screw can be utilized as the same as the primary ACL reconstruction. But if the bone stock is compromised and the quality of interference fixation is not secure, fixation should be augmented with a suspensory device such as screw and prod or ligament button. Next is a concomitant procedure that we will do together with the revision ACL, like the last topic, the osteotomy, corrective osteotomy should be performed if more than 4 degrees of varus with medial OA to correct the coronal deformity. And for the sagittal malalignment, if the posterior tibial slope is greater than 12 degrees, and the patient does not have the preoperative hyperextension, the anterior closing with osteotomy to reduce the posterior slope should be considered. Both medial and lateral instability should be addressed at the same time as the ACL revision. The general recommendation for the threshold of the peripheral instability to address is a grade 2 and grade 3 instability. About rotational laxity, from the latest meta-analysis, revision of ACLR with extra-articular augmentation have better postoperative IKDC score and lower incidence of rotational laxity in the high-grade pivot chip. So the use of ALL or LET for the revision anterior cruciate ligament reconstruction have been described as a beneficial. The meniscus is also the secondary restraint for the anterior restraint. So if the meniscus is injured, we have to repair. And in the case of the post-total meniscectomy, the meniscal transplantation is a choice. The rehabilitation is we have no standard preoperative rehabilitation for the revision. However, we have to consider that in this case, we have to need closer care than primary ACL and slower rehabilitation. Late phase, we have to individualize rehab protocol and goal setting. For the outcome, in the revision, ACLR has a higher failure rate and a longer return to sport activity time and a lower PROM if comparing with the primary ACLR. So the last thing, take-home message, I would like to come back to the name of our topic, revision ACL reconstruction, how to avoid the failure. I would like to put that revision is always challenge, and planning and preparation is the way to avoid the failure. The planning and preparation is the planning for the graft choice, for the stage, for the rehab protocol and concomitant procedure. Thank you.